Hi, this is Eric Yazel. I'm the Clark County Health Officer and want to talk to you today about termination of resuscitation in the pre-hospital setting. This is aimed at our Clark County first responder population, but any other first responders who are watching this probably encounter a lot of the same issues. First and foremost, I want to talk about the Clark County protocol for a deceased patient. This is for all levels. Indications for calling it at the scene: apneic or pulseless patients with one or more of the following: rigor mortis, dependent lividity, which I have some pictures of this I'll show you if you're not familiar, decapitation, decomposition, incineration. Those three are pretty self-explanatory. Then the last one, major blunt or penetrating trauma with no signs of life in initial examination. I have this one starred because it's a little trickier than the others. Contraindications: drowning and or hypothermia. These are ones where the patient may seem to be asystolic or have indications for calling it in the field, but actually are resuscitatable on transport. So do not call these in the field. The procedure: do not resuscitate any patient who meets the previous criteria. If resuscitation efforts are in progress, contact your medical control for physician consultation to consider termination of resuscitation efforts. Also, notify the coroner and law enforcement of the patient's death, or the patient's physician if the patient is in a medical facility with continual physician or nursing care during its hours of operation, essentially your nursing homes. This is a picture of lividity. See the blood pooling on the back there? Another good picture of it. So it seems pretty simple, right? It's obviously not nearly that cut and dried. I'm sure every one of you that's listening right now has encountered situations where you weren't entirely sure what to do in the field. I can't stress this enough. This is a time to utilize your supervisors and medical control. I think those difficult decisions are best made in a group effort and hopefully with the family in consultation as well. One thing I also want to stress, number one and most important, is your safety as a crew. Every one of our first responders that goes out every day, my one goal is that they all come home safely to their families. If you ever need to transport and work because the scene is unsafe and there threats to you on the scene, please do so. And if any receiving facility gives you issue, please feel free to contact me and I will discuss it on your behalf. The other thing I want to say is that dependent lividity I showed you pictures of. That's one of the things that can burn you. Your bedridden nursing home patients, your septic patients, basically anybody with poor perfusion can have skin that looks like that and actually theoretically be a salvageable patient. So that's something to keep in mind. On the other hand, you don't want to transport everybody just out of being overly cautious. Number one, you want to respect the wishes of the patient and their family. Fetal transporter patients have their own risks. You've got occupational exposures, bloodborne pathogens, things like that. Motor vehicle accidents. We've just had a few here locally that, are worrisome. So, and then also you're burdening an already overcrowded emergency department. Working a fetal full arrest takes care away from other patients, that may have better outcomes. The other thing, the reason I starred the traumatic full arrest, I'd have a low threshold to work these outside of any obviously fatal injuries like decapitation, things like that. You'd be amazed at this day and age with rapid transport, some of the new treatments, what level of blunt and penetrating trauma we actually can successfully resuscitate. One thing I say here, the closest facility rule needs to be examined. This obviously depends on where you're at, either in Clark County or wherever the county that you work. But there are basically only two things that'll save a traumatic arrest: rapid administration of blood products in resuscitation and rapid transport to the operating room. The old dynamic used to be that you sent them to the closest facility to be stabilized and then transferred on to, your level 1 trauma center. Well, a lot of the issues, at least here in Clark County, it's only another 5 or 10 minutes over to University of Louisville where our level 1 trauma center is. I do advocate if a patient, is rapidly transferred over there, they can get to the OR and get the rapid blood products they need much more quickly than if they were transferred to one of the other local facilities for stabilization. I work at both places. That's my unbiased opinion. Again, that is just an opinion, but it is also something that's reasonable to explore with your medical control. The other caveat to that is if you've got a patient that doesn't meet the indications to call in the field, but it is a blunt or penetrating trauma arrest that you think is very unlikely to be successful, I do think it's reasonable to transfer to the closest facility more for the purposes of calling it there. But again, if the patient you truly think is salvageable, either in the OR or with rapid blood resuscitation, and you can get to a major trauma center in a timely manner, I do advocate for going to that facility. This is a quick picture of your post form from Indiana. If the families have those are very useful. It can help you guide your end-of-life care. Certainly worth taking the time to look for, and if you do transport the patient, to bring to the hospital with you. Some things to do when you see one. Verify the patient is the person on the name of the form or order. If in doubt, resuscitate. Follow the guidelines in A and B as long as E and F are appropriately signed. Notify the coroner and or law enforcement of the patient's death if no resuscitation will be performed. And attach a copy of the post form to the original of the EMS care report. Apologize, it says post. We all know there's an L in there, but if appropriate documentations cannot be located or verified, you should follow the appropriate protocol. Again, call your medical control for further assistance. Again, I'll say it 1,000 times. Any hairy situation where you're not sure what the next appropriate action is, contact your medical control. Pre-hospital care professionals cannot honor other legal documents such as living wills and verbal such as telephone orders. Again, that's from our protocols. These are also ones that if you do have a clear, declaration of end-of-life wishes that seems reasonable, you can also contact your medical control in that situation. Just some general pearls. If there's any doubt, work the patient. As your medical directors and me as your health officer, we are here to support you and defend you in any situation. It's much easier to defend a situation where the end-of-life wishes were unclear and you worked them anyway than if they were unclear and you didn't work them and the family wanted that done. That's a tough one to defend. In the absence of it just being blatantly obvious that they did not want to be resuscitated, it's really hard for them to come back on you for making an effort to resuscitate the patient. Younger and healthier get benefit of the doubt. If you see, a young traumatic patient, I would be much more likely to be aggressive in their resuscitation than I would an elderly patient with multiple comorbidities. Children and infants, especially in those situations, they always get the benefit of the doubt. The interaction with your families is key. Building a rapport and trust with the families and calming the situation. You'll find that they are much more amenable to making good quality end-of-life decisions if you've built that trust and faith in you from the get-go. Don't forget this either. Outcomes other than successful resuscitation can still be important. What do I mean by that? Just because if you make the decision to transport the patient and the resuscitation isn't successful, there's still other positive things that happen. Sometimes it's just as simple as having the family have time to arrive, hold the patient's hand before they die, and say anything they wanted to say, on a humanity level. On the other side of things, also in a young traumatic patient, they may be able to harvest innumerable amount of organs and save multiple lives from what happened. So there are other outcomes just besides successful resuscitation that can be very important. Don't forget your family dynamic. I've already mentioned it once. You want to be prompt and professional. You want to arrive and, you seem like in a hurry. I'm not saying you need to do a wind sprint from your ambulance or fire truck into the residence, but you want to move in a timely manner and act with some urgency. Remember, you may have done this 100 times, but this is their loved one that's in obviously, an extreme state if we're having this discussion. And, that's a time not to act nonchalant and things like that. You want to act responsible and build their faith in you. Take a quick second to explain your decisions and why you're doing what you can, as long as they're not interfering with your resuscitation. And sometimes you just need to call medical control to get some reinforcement of your decisions. If they're not listening to you on the scene, sometimes having a third-party voice can help you get your point across. The age-old debate of stay and play versus load and go. I'll be honest with you, I don't have a strong preference either way here. The one thing I can't stress enough, 0 interruptions in CPR. Absolutely 0. That's one thing I have concerns on, the stay and play side of things. I'm not there to armchair quarterback you, and that's not something I want to do, but I'm also not there to see if there's any interruptions in CPR. when you load and go, I'm there physically watching you in the emergency department. I can make sure there's no interruptions. Just remember, in this day and age, advanced airway is not the main priority in initial care. Your airway, your access, things like that. Good, high quality CPR is the way to go. I actually had a full arrest brought to me about 6 months ago, and as soon as they came through the door, the medic said, "I'm sorry, I don't have an IV, I don't have an airway." We were just very close, and I just focused on giving good, high quality, uninterrupted CPR, and that was music to my ears. I'm not trying to get all technical with you, and again, this is on determination of death, not resuscitation, but this is actually one of my favorite charts I've ever seen. The whole thing about getting somebody back from a full arrest is getting a certain level of perfusion pressure in the coronary arteries. And what these lines are showing you is it takes about 2 minutes of uninterrupted CPR to get your coronary arteries enough perfusion that you have any chance of success of resuscitating the patient. Every time you stop CPR for more than 5 seconds, that perfusion pressure goes down to 0, and it takes another 2 minutes. So basically, on this top line, what you're seeing is 2 interruptions in CPR. And to get to the point where you might have success, you have to spend time in these areas. Well, see how little time in A, that there's enough perfusion that you might have any chance of success? There's only maybe 20 or 30 seconds. Look at B there. They initiate their compressions and they don't stop, and there's a nice long time frame where there's successful resuscitation possibility. So again, that just kind of illustrates the importance of not stopping CPR. I can't stress that enough. So let's talk real quick about some different rhythms. Asystole, we all know this. Verify in 2 leads. If it's an unwitnessed arrest, no bystander CPR, and you yourself have done 10 minutes of CPR, consider calling medical control. Your chances of successful resuscitation are less than 1 in 1,000. And then always AccuCheck in all these situations. There's nothing more embarrassing than getting burnt in that situation. PEA, that's kind of the toughest one. It's wide or narrow or fast or slow is how they're breaking it down. Narrow is usually secondary to mechanical problems, or like from the right ventricular inflow or outflow obstruction. Wide is typically due to ischemia, metabolic, or left ventricular failure. Slow PEA has a poor prognosis like asystole. Fast PEA, similar to VTAC and VFib. And what I'm trying to stress here is, again, I would have it's more reasonable to call medical control with slow PEA with all the other signs that we talked about earlier, no improvement with CPR and things like that. Fast PEA is similar to VTAC and VFib, so I would definitely work that one more aggressively. You've all seen it in your classes, your 5Hs and 5Ts. I'm not going through that, and we've kind of gone away from that to more this algorithm. If it's narrow, like I said, it's usually a mechanical problem, tamponade, attention pneumo, PE, acute MI, things like that. If it's a wide QRS, then you're thinking more metabolic, hyperkalemia, sodium channel blockers like your overdoses, things like that. So, and then what do you do with that? If it's narrow, you want to give some fluids, and you're doing more procedurally based things. They may need a pericardiocentesis, needle decompression, things like that. These are obviously going to be more destination decisions, but I just want you to begin to think about what may be happening in these rhythms. On the other side of things, if the QRS is wide, again, you're thinking more metabolic, so they're going to need IV medicines versus procedures. Calcium chloride, bicarb, things like that. Your other non-perfusing rhythms, VTAC, VFib, essentially those should never be called in the field. Those are considered, reversible rhythms. And even if it's obvious, if a third party reviews your chart and sees those rhythms documented as the final rhythm, you're just opening yourself up to a lot of questions. Last thing I want to say about that, once you start working the patient, again, no interruptions in CPR. I can't stress that enough. Post-pronouncement, so what are you doing there? Again, maintain your professionalism. Remember, you're potentially always on camera. You're on the scene, you've had a stressful full arrest, you've decided to call it, you have a moment to relax, you may head out to your truck, your ambulance with the other guys. That may be the time to laugh and joke around, and family's still there and obviously have had a devastating moment in their lives. Last thing you want to do is get caught on camera and go viral on Facebook for laughing and cutting up after you just pronounced their loved one. Be respectful and patient. People have different kind of grief reactions. Some may act a fool. Some may be as nice as they can be. Just be patient and respectful as they go through their grieving process. Last thing I want to say is preserve the scene for law enforcement and coroner as indicated. Some things to remember there. Number one, the scene should be a partnership, not a turf battle. Work together with each other. Don't, let your inter-service rivalries get in the way and things like that. From your side of things as a first responder, preservation of life is your number one priority. That being said, after you've decided to call it on scene, there are some things you can do that makes law enforcement's job easier. Number one, a few people enter the scene as possible. This isn't the one to parade everybody in and out to get a look at the body and things like that. Don't move any household items unless there's a safety concern. Medical items should be left in the scene until photographed by a detective or officer at the scene. Don't move anything. All medical personnel on the scene should give their name and information to officers on the scene. Remember, too, any statements made to responding personnel by victims are really important. A lot of these cases go to court, and you want to think about this as you do your documentation. You want your documentation to be something that if it's blown up in huge letters on a courtroom wall by Daryl Isaacs, the Kentucky Hammer, you want to sound responsible, professional, and have a document that you're proud of to review in the court of law. I can't stress the documentation side of things enough. Sloppy documentation is your worst enemy. Your medical directors, from both all first responder standpoints, we're here to help you. I am as your county health officer as well. We want to defend you in your care that you provided in the case that there'd be a bad outcome or issue, but we only can go with the documentation we have at hand. So if a patient's family is upset about some care, and we review your chart and everything's documented to the T, all the T's are crossed and I's are dotted and it's locked down tight, we can do a great job defending you. If we look at it and it's sloppy and we can't tell what in the world went on with the patient, we just can't do a lot to help you. So please give us what we need to be able to defend you. And I say that in general. Any documentation you do from a medical side of things should be done in a way that a third party who was not there presently or at the present time can read it and reasonably understand and assume what happened on the scene there. The last thing, never use disparaging remarks in any way, shape, or form. It may be therapeutic if somebody was acting ugly on the scene to write, things here and there, but I can't stress enough that nothing will make you feel like a bigger fool than if something does go to the court of law that you put something negative about the patient. Number one, it makes you look unprofessional. Number two, it can really, really hurt your case. So always be aware of that. I think that's pretty much it. I'm putting this up on a YouTube channel. My first time at doing this, so please give me some feedback. What worked, what didn't work. Feel free to have some discussion on there. Bring up some specific situations that you might have encountered yourself that you weren't sure what to do with. We can talk, get some feedback in the comment section there. Any other questions or anything you want me to clarify on what we talked about there? Also, we'd like to do something like this every couple of months, so please throw some ideas out there for future talks. Last but not least, too, it's the first responder community. I wouldn't expect anything less than some making fun of me and things like that, too. So anyway, thank you for your time. I appreciate you listening and look forward to see your feedback. Have a good day.